Welcome to today's webinar, ART Options and Treatment Decisions for Women of Reproductive Potentials. I would like to introduce Monica Gandhi, MD, MPH, Professor of Medicine, and Associate Division Chief of the Division of HIV, Infectious Disease, and Global Medicine at the University of California, San Francisco, in San Francisco, California. Welcome, Dr. Gandhi.
Thank you very much. I'm happy to be here with you all. And today I'm going to talk about ART options and treatment decisions for women of reproductive potential. And I'm very happy to take any questions in between or at the end. And please write your questions into the chat box. So please, at this point, to verify your attendance, please in the chat box, as you already have, type your full name and also your institution. And that will allow you to claim credits as a certificate if you're pre-registered, or if you're registered, logged in, and entered into the chat box the same name that you used during your pre-registration. I do want to point out that IAS-USA has a new website, and that's at IAS-USA.org. And you can log in using your IAS-USA account or generate a new account using the email address that you used to sign in for this webinar. In terms of CME information for this particular program, the IAS-USA is accredited by the Accreditation Council for Continuing Medical Education, and this particular program will provide CME for physicians at a level of 1.25 AMA PRA Category 1 credit. And please claim the credit that's commensurate with your participation. In terms of other disciplines, for nursing, this also provides accredited units for the American Nurses Credentialing Centers Commission on Accreditation, and this is also approved for 1.25 hours of continuing nursing education. And then in terms of pharmacy credits, this particular program is also approved for 1.25 hours of continuing pharmacy education credit. So thank you for joining and getting credit. And then in terms of grant support for this webinar, we are supported by unrestricted grants from specific pharmaceutical companies, including the platinum supporters of Gilead, Merck, and ViiV, and additional support is provided by Janssen Therapeutics, again, unrestricted educational grants. So in terms of navigating the webinar as we go along, there'll be a separate window which will show polling questions, because I'm going to ask a couple of pre-webinar questions, and then you'll answer before and after. And so choose your responses from that particular poll window, and it will be obvious because the poll window will come up, and then you'll choose your answer from the poll window, not in the chat box. And then if you want to send any questions, again, please put them into the chat box. And though if I see a question that I can answer in real time, I absolutely will try to do that. Otherwise, we'll compile a list of questions and then answer them at the end of the webinar. Okay, so we're going to start with actually these poll questions. And the first one is easy, which is, from which geographic region are you viewing this webinar? So please put in by poll answer what reflects where you are in the country or where you are internationally. Okay, it looks like answers are, oh no, still a few coming. Okay, the poll is closed. Okay, so sorry about that. Jose, I'm sorry. Could you, are the participants able to see the results of the poll?
Yes.
Okay. I am not able to see the entire results, but I'm going to proceed. Okay. Now the next question is, please rate your level of experience in the medical management of HIV infection. And the answers here are a novice, and that would be answer number 1. 2 is some experience. 3 is more experience. 4 is even more experience. And 5 really is you rate yourself as an expert in HIV medicine. Okay, so the poll is closed, and you should be able to see the responses there, about 32.5%, somewhere in the middle, and a little bit higher percentage in terms of expert or or a little bit less than expert. So just 9% novices on the call. Okay, next slide. So I'm now going to start the talk, and again, I'm happy to take questions in between if there are any burning questions. Otherwise, we'll take them at the end. I have no relevant financial affiliations to disclose, and this talk has been peer-reviewed and also reviewed by our CME planner. So in terms of the learning objectives of this talk, upon completion of the webinar, hopefully you'll be able to, number 1, describe the recent data linking dolutegravir to the signal of possible neural tube defects. 2, describe the recent guidelines, and we're going to focus on both high-income and low-income settings for ART options in women of reproductive potential and pregnant women. 3, understand ways in which the pharmacokinetics and the safety profile of antiretroviral agents during pregnancy can be explored. 4, hope to provide practical tips for treating women with HIV during pregnancy or reproductive potential. And then finally, we're going to really end with new initiatives on including pregnant women in clinical trials of new medications after convincing you throughout the talk that we don't have enough information on these major drugs and their use in women of reproductive potential. So this is your pre-test question number 1, and we'll also be asking this question after the talk. So the question is, which drug is first line on both the Department of HIV and Human Services guidelines and the WHO guidelines for use during pregnancy? So both in the United States and the WHO guidelines. Is it number 1, dolutegravir after the first trimester? Is it number 2, efavirenz? Number 3, tenofovir allocinamide? Or number 4, atazanavir ritonavir? Okay, so we'll come back to this in the post-test, but a very interesting range of responses. And then the next question, as a pre-test question, is what is the rate of neural tube defects in the general population? As we discuss what's been happening with INSTIs and neural tube defects, what about in the general population? So number 1, 0.1%, 2, 0.4%, 3, 0.67%, or 4, 0.9%. So we'll come back to this again at the end, but most of the answers came in between 0.1 and 0.4. Okay, next question. So in terms of the outline of my talk, I'm going to give you some key background points. And then we are going to dive right into the neural tube defects question and what is the recent data on Dolutegravir and NTDs. We'll talk about treatment options for women with HIV of reproductive potential. We're going to talk about the pharmacokinetic issues and why drugs can look so different during pregnancy. And then we'll come back to practical considerations on ART during pregnancy. I will make a comment and try to keep it simple on PrEP, contraceptive drug-drug interactions, and just the general concept of studying drugs in pregnancy, and end with a cry, essentially, for more data being needed. So in terms of key background points, there are actually very few true teratogens known that affect the fetus if the mother takes the medication during pregnancy. And in fact, in the former FDA classification, these drugs used to be called Category X. And I'll tell you about the new FDA classification of the safety of drugs in pregnancy. But examples of the former classification of Category drug X drugs included Accutane, valproic acid, warfarin, or methotrexate. Most drugs simply have not been studied enough in pregnancy. The new classification system of the FDA is called PLLR, or Pregnancy and Lactation Labeling. And that really is a classification system in which the data is summarized for each drug about what we know about its use during pregnancy. And in general, we don't know a lot about many of our drugs. We may only have post-marketing cases where there's been a safety signal. For example, these 4 cases where babies were born with neural tube defects of women who were taking Dolutegravir, which I'll tell you about, and really not well-designed human studies. And what that leaves us with is that providers are often left flying blind. And this is a publication that I'd really like to refer you to in JAMA last year called Addressing Barriers to Inclusion of Pregnant Women in Clinical Trials by Rita Rubin, a journalist. But her quote is that physicians are often left flying blind when trying to determine whether a drug has a favorable risk-benefit profile in pregnancy. And importantly, another comment made in this summary article from JAMA is made by the Director of Bioethics, Associate Director at UNC, Ann Lyerly, who I will quote later in the talk. But she actually says in this article, the first thing we've had to do is to argue that the status quo of how we study drugs in pregnancy and that is unethical. You must do research with pregnant women because not doing so is unethical. And that's going to be really a mantra of the talk as we go along. Okay, so why are we talking about this and why is there a new focus on ARVs during pregnancy? Well, new data last year did shift attention to this topic, and that's part of the reason we're doing this seminar and part of the reason why there's so much discussion of what to do with pregnant women on antiretroviral therapy. So what happened last year? Well, before I tell you what happened last year, I want to give you a little bit of background and a reminder of the timing of in utero exposure to any drug, actually, and the risk to the fetus. And this slide is courtesy of Lynn Lofinson. And what you can see in the terms of the stages of fetal development is that really the effects of, quote, possible teratogens usually are exerted in very, very early on in pregnancy. So the neural tube closes very early on in pregnancy. So really, actually, for example, the first 2.5 weeks after fertilization, this is called the pre-organogenic period, and generally nothing in this first 2.5 weeks can affect organ development in the fetus. It's really in the weeks 3 to 8 post-fertilization is that period of embryogenesis where major organ development is occurring. And that's really the most sensitive period of the fetus to teratogens. So for example, the neural tube closes by day 28 after fertilization, and oral structure, for example, the mouth and closing of any palate, occur by day 36 of fetal development. So what happened in May, and why did attention turn to this issue? Well, essentially this all came from a cohort study that's been conducted in Botswana called the Tsamo study. And really what this study is doing is that it isn't a randomized trial. It's an observational cohort study because efavirenz is being used in women of childbearing age, and Dolutegravir was being rolled out in the country of women of childbearing age. And really the entire purpose of this observational surveillance study was designed to evaluate the risk of neural tube defects with preconception efavirenz exposure, because there's always been a question from animal data if preconception and exposure during efavirenz in the first trimester would affect the neural tube. So really what was happening in the country was that prospectively birth outcomes were being surveilled for major surface birth defects. And the Tsamo cohort covered 8 large maternity wards. It's population-based, and it actually covered 45% of Botswana births among women living with HIV. And so when babies are born, as the Tsamo cohort was being evaluated, trained hospital-based midwives were examining the newborn, and then a research assistant was consenting the mother for a photo of the newborn, and then there was an independent review of these exposures, of these birth defects that were performed by a medical geneticist, and this independent review was occurring where the geneticist was blinded to exposure. And this was being examined in both HIV non-infected women and in women who are living with HIV. And as you all, or the majority of you answered, the prevalence of neural tube defects in the general population is around 0.1%, and that was what was seen in the Tsamo cohort, that there were 86 neural tube defects among births in the general population at 0.1%. But what did we see among women who were taking different antiretrovirals before pregnancy or in the first trimester? And you can see that of these 4 drugs, so either being on Dolutegravir, being on a non-Dolutegravir regimen, being on efavirenz, or Dolutegravir started during pregnancy, you can see that there was an increased signal or for neural tube defects for women who were, and their babies, who were taking a Dolutegravir prior to conception or very early on. And that overall rate of neural tube defects was, of babies born with neural tube defects, was a total absolute number of 4. The denominator of women in that first strata was 426, and 4 over 426 leads to a 0.94% rate of neural tube defects of babies born to mothers who were exposed to Dolutegravir early on. This is higher than the general population, and certainly higher than any of these other strata, for example, including the women who were exposed to efavirenz, who were taking efavirenz early on in pregnancy at 0.05%. And then what were these neural tube defects of these 4 babies? They were all totally different phenotypes. One was a frontal encephalocele, one was anencephaly, one was lumbar myelomeningocele, and one was a stillbirth. And there was no particular geographic clustering, no predisposing factors, for example, among the families, no other drugs that could lead to this. And of importance to note is that Botswana does not have folate food supplementation in grains, for example. And so then this data was updated at the International AIDS meeting in Amsterdam. The first set of data that I just showed you was published in the New England Journal by Rebecca Zash and others, but there was an update provided at the International AIDS meeting in Amsterdam where essentially the update showed that there were more women in the denominator that could be gathered, and there were no new cases of neural tube defects, at least among the babies born of mothers where Dolutegravir was started prior to pregnancy or early on. So the denominator in that case grew to 526, the number of babies born stayed at 4. 4 over 526 became 0.67%. And that was the update that was provided at the International AIDS meeting. Again, still higher than the general population, still higher than seen with the efavirenz, but there was a higher number of women in the denominator, which led the rate to come down a little bit of neural tube defects born of mothers, of babies born to mothers who were exposed to dolutegravir early on. 0.67%, 4 over 596. And what we expect to see and what we're hoping to see is that we were hoping to get this data at the end of March, but I don't believe we will. I believe the data will be gathered a little bit later, and we're all going to see, hopefully, data eventually from where the denominator grows to 1,400 births. And at that point, if the number of neural tube defects stays the same, then the rate will go down even further. This is where we are in the world. This is what we have. This is all we have in terms of data. So we're going to come back to this because there was a question asked in the pre-registration questions about, is there a possible mechanism for this? Is this real? Is this class effect? These are all excellent questions, and I'll try to come back to it in as much as we know about the data. Okay, so let's take a detour from dolutegravir for a minute and come back to the overall question is, what do we know about ART in women of reproductive potential or who are pregnant? Well, let's start with the number of drugs that are available in 2019 for treating HIV infection in women, men, anyone. These are the number of drugs that are available. You can see that in 2019, I've grayed out the drugs that we don't use, but otherwise, it's an amazing array of antiretroviral treatment options, at least in the United States and high-income settings. There's a number of different drugs that have been approved for the treatment of HIV infection in adults. However, if we advance to the next slide and take away the drugs that have never been studied in pregnancy or we don't have any information in pregnancy, you can see that quite a few drugs are removed from that list. So showing you again, these are the number of drugs available for the treatment in adults, and these are the number of drugs that come off when we're exclusively looking at the ARVs that we have enough data about in pregnancy. Doesn't mean we don't use them, but these are the drugs remaining where we have at least accumulating information from safety and post-surveillance that we feel comfortable using them in pregnancy. So let me be more specific about that. You can see that among the NRTIs, it's sort of divided into two classes of medications. There's drugs where we don't recommend the drug during pregnancy, and then there are drugs that we use for the treatment of adults that we simply don't have enough data. So for example, in the classification of drugs that are not recommended during pregnancy, and I'm going to go over some of these reasons why, the drugs that are not recommended during pregnancy are anything that contain cobicistat as a booster, and I'm going to talk about why later in the talk, but albutegravir cobicistat, TAF-FTC, atazanavir cobicistat, darunavir cobicistat, or the new single pill combination that contains a PI, darunavir cobicistat, TAF-FTC. None of those are recommended during pregnancy because of pharmacokinetic concerns. Nevirapine, etravirine are both NNRTIs that are not recommended during pregnancy. Maraviroc is the only CCR5 antagonist we have, and it's not recommended during pregnancy. The only entry inhibitor that we have that's injectable, T20, is not recommended during pregnancy, and dolutegravir, rilpivirine, the single pill combination that's NRTI sparing, is not recommended. Drugs for which we don't have enough data are tenofovir, alafenamide, dolutegravir, doravirine, and then the combinations that use those drugs. And then also the new drug for MDR-TB, ivoluzumab, we also don't have enough data. And the problem is, when I've mentioned dolutegravir and TAF, for example, those drugs are often used in non-pregnant adults, but we simply don't have enough information in pregnancy. And so what we're left with, and these are the guidelines, at least as published by the DHHS guidelines, and I'll give you a little bit of data from the British guidelines and European guidelines, this is what we're left with in terms of what are truly either preferred or alternative drugs to be used for pregnancy. And in the NRTI class, zidovudine is listed as an alternative drug. And so the only drugs that are preferred are either bacavir 3-TC or tenofovir disoproxil fumarate and FTC, or the brand name of Truvada. And in NRTI class, there's not a single drug that's preferred, and efavirenz and rilpivirine are listed as alternative drugs, at least in the US-based guidelines. Among the integrase inhibitors, only raltegravir is listed as preferred throughout pregnancy because of the data that we just went over with dolutegravir. Dolutegravir is only listed as preferred after the first trimester. Among the protease inhibitors, only atazanavir ritonavir and darunavir ritonavir are listed as preferred agents. Lopinavir ritonavir in the U.S. guidelines is listed as an alternative. And then in terms of single pill combinations, there's actually not a single pill combination that is listed as preferred, except during the second trimester, which is the brand name of Triamec, dolutegravir, bacavir, and 3-TC is preferred, but only after the first trimester. So none of the other single pill combinations that we use so commonly in this country are listed as preferred. And there's a little bit of difference with the European guidelines and the British guidelines. The European guidelines list raltegravir and atazanavir ritonavir as preferred, and the British guidelines list efavirenz and atazanavir ritonavir as preferred because of accumulating data with those. So more along the lines of the WHO guidelines there with the British guidelines. What about the guidelines worldwide from the World Health Organization? Well, these are listed as the preferred first, second, and third-line ART regimens in adults and adolescents, and these include pregnant women and women of childbearing potential. So as we know by this point, the first-line regimens that are recommended are really 2 NRTIs and dolutegravir. The combination of TLD or TDF, lamivudine, and dolutegravir is really first-line worldwide. Whether it's rolled out completely or not, which it's not, this is the preferred first-line regimen. But there's a big caveat, and you can see that listed there as B, as a side note, that in women of childbearing age, that is not recommended until after the first trimester. That leaves us for first-line regimens with 2 NRTIs and efavirenz listed as the preferred first-line regimen for women in the first trimester. And then if you look at the second and third-line regimens that are recommended worldwide, atazanavir and lopinavir are recommended, and that would both be for women of childbearing age. And then a third line, really, that's when we're looking at darunavir, ritonavir, and dolutegravir with or without NRTA, hopefully based on resistance data. So again, to make it simple, it's dolutegravir or efavirenz for pregnant women for first line, but dolutegravir only after the first trimester. Okay, so let's go back to dolutegravir for a minute and discuss some of the questions that have come up for you about integrase inhibitors and the class effect of these. As I already indicated, really the guidelines worldwide are harmonized. Whether you look at the European guidelines, the British guidelines, the US guidelines, or the World Health Organization guidelines, consistently worldwide, dolutegravir is not recommended when trying to conceive and during the first trimester, but dolutegravir is recommended in all of those guidelines after organogenesis is complete. In terms of this question that you've raised in your questions that you put in even prior to this webinar, the question that many of you had is there a class effect of integrase inhibitors? Well, it's an excellent question, and the answer right now is, number one, we don't even know if this is real for dolutegravir. And number two, we don't have any good evidence that this effect has been seen for any of the other integrase inhibitors. So we don't have good data, on the other hand. The TESAMO cohort is unique, and it's looking at dolutegravir because dolutegravir was being rolled out in Botswana when the surveillance cohort was being established. We don't have great data for the other drugs, but there hasn't been a post-surveillance signal. For example, if we look at data to the antiretroviral pregnancy registry or any of the registrational trials by the drug companies, for example, we don't have any signal for neural tube defects being seen with Dolutegravir, for which we have the most experience because Dolutegravir was released in 2008, and we don't have any signal with Dolutegravir an increased risk of NTDs. And then at least the Gilead registrational trials looked at Dolutegravir, and there were 389 births on Dolutegravir, and this was data that was shown only in abstract form at the HIV Glasgow conference in October of 2018. And you could see that with Dolutegravir, at least of those 389 births, there were no neural tube defects. We can't comment on neural tube defects with Dolutegravir. It's simply too new. It's only been out for a year. And there have been other looks at cohorts from Canada, Germany, Eastern Europe, and there doesn't seem to be an increased risk of neural tube defects in Dolutegravir. But all of that relies on providers such as ourselves on the phone putting in data to the antiretroviral pregnancy registry that a woman's been on Dolutegravir, and I'll make a plea for that later on. We have actually looked at some data in our lab, and so have other groups, if there's any effect on folate transport across cells of Dolutegravir. Importantly, of course, folate is essential for neural tube defect formation, and folate transport across the placenta is actually an active process. So if a drug interferes with that active folate transport, that could be a possible mechanism implicated for the effect of Dolutegravir on neural tube defects. And so we looked in our lab, and this is data shown here, at a cell model where we put in drugs at physiologic concentrations and even at higher concentrations that you'd see in the intestinal lumen of Dolutegravir and Dolutegravir and Raltegravir and Bictegravir, so all the MCs, and looked at if they had an effect on active folate transport across these cells. And you can see that at least by the lines sort of looking like the control line, that we didn't see a major effect on active folate transport across cells with Dolutegravir or any of the integrase inhibitors. And the red bar there is methotrexate, or sort of a folate transport poisoning mechanism. And you can see that there is an active effect with that control. So that doesn't seem to be the mechanism, but we need more data on that, and that's actively being looked at by a number of groups around the country, and the NIH is calling a special sort of session together later in April to look at any data that anyone's been looking at for possible mechanisms of this. So I would say we don't know the mechanism. We don't even know if it's real, but that's where we are in the world. Okay, let's talk a little bit about pharmacokinetics of different ARVs in pregnancy before we get to the practical tips, because pharmacokinetics are important to consider for why some of those drugs weren't recommended. Because I said that there was a group of drugs that weren't even recommended during pregnancy, and where do we even know anything about that? A lot of that is based on pharmacokinetic differences that occur during pregnancy. So if we remember what are the components of pharmacokinetics of drugs, even without pregnancy, there's really 4 components of how a drug gets into the human body. These are called ADME. And those 4 components of pharmacokinetics are absorption, distribution, metabolism, and elimination. And even before we get to pregnancy, there are absolute differences between men and women and how they process drugs. There are obviously sex differences in PK, even when we don't consider physiologic changes that occur during pregnancy. So for example, in the category of absorption, women have lower gastric acid levels in their gut. They have slower gastric emptying time that actually varies throughout the menstrual cycle and varies with use of oral contraceptive pills, for example. Women have different diets, and they may have different absorption as a result. But it doesn't seem like women and men have different levels of metabolizing enzymes to transporter enzymes in the gut. In terms of distribution and how a drug is carried around the human body in the circulation, women in general weigh less. They have more proportional fat. They have varying plasma volumes, so again, they vary throughout the menstrual cycle. And estrogen itself has effects on plasma binding proteins that actually carry around these drugs. So there's reason to think why women and men would be different in terms of carrying around drugs. In metabolism, or how drugs are broken down in the liver, in vitro, at least it looks like progesterone in women, which of course is higher in women and it varies throughout the menstrual cycle, increases cytochrome P450-3A4 activity. And CYP3A4, or the cytochrome P450, is one of the main metabolizing enzymes for a number of the antiretrovirals. And this would fundamentally lead to lower drug levels in women from different metabolism effects. But in terms of elimination, well, in general, women have smaller organs. They have smaller kidneys, they have smaller livers. And because there's less blood flow to those organs, then women eliminate drugs at a lower level, and this would lead to a general trend for women having higher drug levels than men. And then what about what occurs during pregnancy? Well, what occurs during pregnancy is that there are effects of all of these parameters, and they're even more exacerbated during pregnancy. So, for example, in pregnancy, there's even slower gastrointestinal motility and lower gastric acid secretion. That's the effects on absorption. In terms of distribution, there's increased body fat in pregnancy, and there's expanded intravascular volume. And with expanded intravascular volume, your denominator of your intravascular volume goes up, so it looks like you have lower drug concentrations. In terms of metabolism, is affected by progesterone, and progesterone levels are high during pregnancy, and so that makes drugs metabolize faster. And then in terms of elimination, renal blood flow is increased during pregnancy, and all of these effects in general tend to lower drug levels in pregnancy. In a very general way, all drugs seem to have lower drug levels in pregnancy than they do in the non-pregnant state. So let's give an example of the latest drug that's been looked at with these effects during pregnancy. The latest drug that's been looked at is Dolutegravir and cobicistat, and this is the IMPACT study 1026, and this is the data from the AIDS publication that I'm showing you here. And you can see that compared with paired postpartum data, Dolutegravir area under the curves were lower in the second trimester and even lower in the third trimester among this group of 30 pregnant women. And cobicistat levels are even more pronounced. They're much lower in the second trimester and even more lower in the third trimester. And cobicistat is essential to boost the Dolutegravir levels. And importantly, in this tiny little study of 30 women, there were actually women of the 25 that could be assessed with viral loads that broke through with viral loads, meaning their HIV RNA at delivery was not suppressed in 25% of women on Dolutegravir cobicistat, speaking to the importance of these drug levels in the third trimester. So all of this data put together has made the DHHS and other guideline committees say that cobicistat should not be used in pregnancy because of these pharmacokinetic changes, and that you should even consider switching out these drugs during pregnancy, or if you don't switch, more frequent viral load monitoring during pregnancy because of these really dramatic PK effects with cobicistat. And then if we look at the other major antiretrovirals and what we know what happens to their levels during pregnancy, kind of putting a lot of data together, and the references are there on the right. With tenofovir, in general, tenofovir and tenofovir diphosphate levels are lower in pregnancy, but there doesn't seem to be a major clinical impact of that, and we have a lot of experience with tenofovir, so there's no recommendation to change the dose of tenofovir. Rilpivirine levels do decrease in pregnancy, but it's highly variable, and there doesn't seem to be a major clinical impact, and the recommendations are just to watch women on rilpivirine, and this is why this drug is considered alternative and not preferred. Lopinavir and ritonavir levels do decrease during the second and third trimester, and some experts have said, okay, because of that, increase to 3 tablets of lopinavir twice a day in pregnancy, but that's hard to take. It's quite nauseating, and this is hard to take in pregnancy, so it's not all experts who have recommended this. Darunavir, ritonavir levels do decrease during the second and third trimesters, and in fact, the DHHS guidelines, as a result, have recommended that darunavir and ritonavir should be used even from the first trimester on as twice a day at higher concentrations. By the way, that is not recommended by the European guidelines, but that twice-a-day dosing because of lower PK is recommended by the U.S. and British guidelines. Atazanavir, ritonavir, no one says to make any changes in the dose, but it is important to know that the PK does decrease during pregnancy. And then finally, Dolutegravir also decreases during pregnancy like all of them, but it doesn't seem to have major clinical effects. But the recommendation by all the guidelines committees are to use the dose of 400 milligrams twice a day, not the 1,200 milligrams once a day that we can use in non-pregnant adults. Okay, I'm actually going to answer, there's some very good questions from the audience, and please hold those, and I'm going to come back to answering those at the end of this practical tips. So putting it all together in terms of practical consideration. Let me go through this, and then let me answer the really great questions that that have been posed to me, and I think fit really well at the end of this practical consideration. So in terms of practical considerations, what should you consider when you're choosing the ART regimen for your woman of reproductive potential? Number 111 is patient preference. It is absolutely a dialogue between you and your patient, and I'm going to talk about what patients think about when making this decision. Number 2, remember that if you switch, it can be disruptive, and there's been many case reports about switching and how that can be disruptive, and sometimes just keeping people on the same regimen and watching them more closely is a better approach. Think about in pregnancy, gastrointestinal concerns. There's nausea and vomiting with protease inhibitors. There's gastroesophageal reflux and heartburn that occurs during pregnancy, and there's some drugs that don't mix well with antacids. So we're gonna talk about that in a minute. Think about other drugs that the woman may be on and pharmacokinetics. Remember that any woman that has hepatitis B needs to be on TDF and FTC as their backbone, because AZT and abacavir will not affect and treat Hep B. And then if your woman really needs a single pill combination, that is okay. Just remember that only dolutegravir, abacavir, and CTC is preferred after the first trimester. But again, because it's a dialogue between you and your patient, what's preferred may not be what you end up using. And actually, I do want to show you this picture because I thought this was really a great picture of women who were demonstrating at the International AIDS Society in Amsterdam right before the WHO released their guidelines about dolutegravir being first line worldwide, and even for pregnant women. This was a very peaceful protest that occurred right before the WHO Guidelines Committee announcement, where women are holding up signs that said, "Let women decide if they want dolutegravir. It's my choice," and women demand dolutegravir, knowing that dolutegravir had obviously potency benefits and resistance benefits over efavirenz. Okay, this is a really nice study that was in BMJ Open last year or 2 years ago about what do women value who are living with HIV when they're considering their choice of antiretroviral pregnancy. And this was data accumulated over 15 qualitative studies. And what women value, first and foremost in 10 studies, is distress about side effects. It's hard enough to have side effects of pregnancy, and having an antiretroviral added to that distress is not helpful. So absolutely consider the side effects of the antiretrovirals that you choose. Number 2, the desire to reduce vertical transmission was considered by in 9 studies among women. That was the second most important reason. Concern about side effects to the child was listed as the third most cited reason. Desire for child to be healthy was listed in 5 studies as the fourth reason. Desire for oneself to be healthy was in the same number of studies. And then pill burden was listed by women in 2 studies. So do remember that patient preference matters a lot. If you look at the DHHS guidelines, there are a number of drugs that if they're on it, you don't have to switch them off of the drug. If a woman is taking it, they're happy on that regimen, switching can be disruptive, and you don't have to take them off of the drug. They can be continued. You just may have to watch them a little bit. So, of course, all of the preferred or alternative agents on the DHHS guidelines should be continued. That includes bacavir, 3TC, TDF, FTC, zidovudine, dolutegravir, efavirenz, atazanavir, dolutegravir, and lopinavir. But if a woman is on TAF, the DHHS guidelines don't recommend to take her off TAF, but to continue if she's happy on that regimen. Etravirine, rilpivirine, nevirapine, Maraviroc, and T20, you can continue to just watch. Again, they're not maybe recommended in pregnancy, but switching can be disruptive. The drugs that are recommended to switch the patient off of are really only a couple. One is Dolutegravir during the first trimester, and importantly, atazanavir and cobicistat, Dolutegravir cobicistat, or elbapixant cobicistat. So if a woman's on cobicistat, given the PK data that I showed you, until we can get a little more data, cobicistat is really not recommended during pregnancy because of its decreased levels, and you should consider switching women off of any of these boosted drugs. Dolutegravir, doravirine, and ipilimumab are just listed as having insufficient data. Not a lot of people are on ipilimumab, but and not a lot of people yet are on doravirine worldwide. But dolutegravir, it's sort of insufficient data, and it's a discussion between you and your patient. Other considerations that I want to list during pregnancy, and then I'm going to go to some questions, is that for efavirenz, again, we all know that primate studies raise concern about neural tube defects, but this simply has not been seen in human studies, and basically at this point, this is considered a safe drug. But efavirenz can lead to intrapartum and postpartum depression, and consider that and be aware of that. Rilpivirine, this is not a drug that should be used with any adults who have CD4 counts less than 200 or HIV RNA levels greater than 100,000. It's not as potent in those populations. And also, pregnancy is a state where there can be a lot of heartburn, and you really can't use proton pump inhibitors at all with rilpivirine, and you have to stagger out H2 blockers. So this is not a great drug to use if someone's having a lot of heartburn during pregnancy. In terms of dolutegravir, in at least in non-pregnant adults, we can actually at this point use the dose of 1,200 milligrams PO daily. That is not recommended during pregnancy, and the recommendation is to use 400 twice a day. And dolutegravir and all the integrase inhibitors do not mix well with cations, and so you do have to separate your doses of dolutegravir if the woman is on iron during pregnancy or using antacids that contain aluminum and magnesium. NSTs do reduce the viral load fast, and that's a major advantage during the third trimester. If a woman presents late during pregnancy, adding an integrase inhibitor that was just presented at CROI is great for bringing down the viral load fast, which can reduce the risk of vertical transmission. Atazanavir and ritonavir and darunavir and ritonavir, okay, of course, used during pregnancy, but do remember that atazanavir is associated with hyperbilirubinemia that can lead to neonatal jaundice. And darunavir, ritonavir, as I already told you, is recommended at twice a day during pregnancy, at least by the DHHS and British guidelines, not by the European guidelines. So I'm going to go to a couple of your questions at this point as we finish up the practical tips. There is a question that when I had early on showed the drugs that were grayed out in the slide labeled ART 2019, those drugs that are grayed out are not recommended for anyone. So we are no longer using D4T ever, or should be. We are barely using DDI. We are should not be using vidanicine or nalfinavir. So those drugs are grayed out on the ART 2019 slide that I showed you before for anyone, pregnant or not. These are just simply too toxic, too old, and not recommended for anyone. Another question that was raised is, I'd already told you that preferred agent, at least for NRTIs as initial treatment, is TDF, FTC, and not zidovudine 3TC, at least by the DHHS guidelines. But a very good question is brought up about the PROMOTE study. So the PROMOTE study was a really important study promoting maternal infant survival study everywhere. Sorry, and it's not called the PROMOTE study, it's called PROMISE as its abbreviation, so the PROMISE study. And it found that zidovudine 3TC was effective, of course, in reducing perinatal transmission, and it is cheaper and at least in that study, there were few complications with it. And so the question that I've been asked is my opinion. I do think that zidovudine still has our side effects of anemia that can be problematic in maternal, in the use by mothers during pregnancy. And there is much debate about what happened with TDF in the PROMISE study. But the babies born of mothers who were taking a combination of TDF with lopinavir and ritonavir were the ones that did worse. And importantly, ritonavir is a drug that actually boosts the levels of TDF, and this is really important to know about. So ritonavir, of course, is a pharmacoenhancer that boosts the levels of protease inhibitors, but it also actually boosts the levels of TDF up to tenofovir itself. And so there was a question raised in that trial, and there's a lot of ongoing study about this, whether it's the combination of TDF and ritonavir that's more problematic because of ritonavir's influence on TDF. At least worldwide, I would still recommend TDF 3TC because TDF 3TC is not often being combined for pregnant women, at least in first-line therapy, with ritonavir-containing regimens. It's being combined with dolutegravir and efavirenz. And in that case, without the booster, it seems very safe. Then there's a question about commenting on preferred regimens for adolescent females of childbearing age who may not be using reliable contraception. There is going to be a section where I'm going to talk about contraception, so I'm going to defer to that a little bit, but I will say that the point that is raised here that a single pill combination is preferable for adolescents, absolutely. And I think that this is preferred for people everywhere, like using a single pill combination. And so, again, I think it's tremendously important to say there are guidelines, they're what we know, and then there are drugs that are generally safe. And if the woman is happy on her single pill combination going into pregnancy, based on the data I just showed you, continue that single pill combination. Watch and counsel, but continue it because it can be more disruptive to switch. And then another question is, what are recommendations for ARV switches in women prior to pregnancy if they've been stable on INSTI regimens with dolutegravir prior to conception, for example, in preconception planning? Do you recommend switching to another INSTI or changing class and resuming dolutegravir after the first trimester? This is an excellent question. Again, decision made with herself. She may love her dolutegravir. It's been 4 cases. We're going to get more data on this, and if that's what works for her, then that's what works for her, and keep her on it. However, yes, by the guidelines, the recommendation would actually be to switch to raltegravir as your preferred agent as in preconception planning, and that's 400 BID, at least in the DHHS guidelines, or efavirenz in the WHO guidelines, and that's an alternative regimen here in the U.S. Switch her back after the first trimester. So that would be the strict guidelines, but I think for those of us who treat women and for those of us who are engaging in discussion, that may not be what she wants. And if that's not what she wants, then it's our duty to tell her the limitations of the data that we have. And we don't have that much data. We have 4 cases. And by September, I'm really hoping we're going to have enough women in that denominator in the Sasamo cohort that this effect or this signal could even go away. So we need to wait. We're at a very tenuous point in terms of our counseling, and I think it's a discussion as much as possible. Cognitive disorders associated with these drugs. HIV. So exposed infants in utero to antiretrovirals, as an overall comment, the best thing you can do is, treat the woman. That's the best thing for her health. The best thing you can do is treat to reduce the risk of perinatal transmission. So overall, those benefits far outweigh the possible risks. There are some risks of preterm birth, but there hasn't seemed to be any clear associations with any. It's listed here: autism, ADHD. There hasn't seemed to be any clear link between exposure to antiretrovirals and infants born and eventually developing those conditions. And then And then another question is, with the breakthrough viral load with elbit in pregnancy, any other PK factors such as increased weight could explain the results? I think that's a great question. I have heard rumors of another study that has just been released, and maybe someone can tell about it at the end. And I'm waiting to see the results where there weren't these virologic breakthroughs with this. This was 30 women. And you're absolutely right that 30 women has limitations of 30 women and a small sample size. And so I think that that's where we are at the moment with cobicistat, that it's looking very concerning in terms of decreased levels in the third trimester. But more data is coming, and that may change the recommendations for elbit. And then finally, any recommendations for ART and elite controllers during pregnancy? That's an excellent question. I'm giving you the bias of the division in which I work and at ECSF, and we believe in treating elite controllers no matter who they are for sort of anti-inflammatory effects, and in general, you know, blips that could lead to the possibility of viremia that could lead to transmission. So I'm going to come heavily in favor of always treating everyone with HIV, including elite controllers. Okay, I'm actually going to go on, and then I think we'll have more questions. So in terms of monitoring of HIV labs during pregnancy, I think this CROI was really important in terms of a greater call, and this has been also published, of more frequent virologic monitoring during pregnancy in women in low-income settings. Okay, it's expensive and it's hard to get, but if there's any place where we need to prioritize viral load testing, it's during pregnancy. And there's some very nice posters that I list at the bottom at CROI, and also papers that I list at the bottom about the modeling of why we need more viral load monitoring during pregnancy. In this country, in the DHHS guidelines, HIV RNA is recommended at the first visit, 2 to 4 weeks after starting or changing ARVs, monthly until undetectable, and then every 3 months in pregnancy, and right before pregnancy to establish what should be done during delivery. The recommendations for CD4 count is at the first antenatal visit, and then only repeat if it was low, if it was less than 300, or if they're detectable viral loads. The other labs to monitor are drug resistance testing if there is a viral load that's above 500, which is what's required for the assay during pregnancy, and also performing labs kind of per the typical adverse effects of the antiretroviral agent. So, so if it's bilirubinemia, hyperbilirubinemia with atazanavir, then specifically looking at that. Standard glucose screening, some experts will say for those on PIs, do it earlier than the usual 24 to 28 weeks of pregnancy to monitor for perinatal diabetes. And then ultrasound to confirm dating, especially given this Dolutegravir question, is recommended by the DHHS guidelines. And again, viral load during pregnancy, not just in high income but in low income settings, is absolutely being called for, and I completely agree. I do want to make just a couple of comments on the preconception question and also on PrEP. To summarize a lot of data on PrEP at once, it's safe. This is a really nice meta-analysis, systematic review meta-analysis of the safety of TDF in pregnancy, and this is notably among women living with HIV, but that would, of course, be the same drug that's used for pre-exposure prophylaxis, TDF-FTC. It's generally safe in pregnancy for both women and infants. There may be some bone effects that are hopefully reversible. I will say that the risk of HIV incidence in the pregnancy and postpartum regions times, and the risk of that subsequent transmission to the fetus with acute HIV infection is so high that there's no question that, it's critical and must be encouraged for women at risk during these periods. And then in terms of the periconception period, of course, women of childbearing age should always have reproductive desires discussed. There was earlier data in the U.S. that every other woman except those living with HIV, that's what they talk about at their usual primary care visits. And of course we should be discussing, and that doesn't happen with women living with HIV, of course we should be discussing reproductive desires with our women of reproductive age. And if the the reproductive desire is not at this point to conceive to discuss contraception. And I really do want to make it very simple in terms of contraception. I feel like I'm doing a disservice to all the great studies that have gone in to all of this data, and I'm trying to make it really simple here. But in terms of contraception, NRTIs, there are in general no interactions, although there's been some recent data that feminizing hormone therapy for transgender women may reduce tenofovir diphosphate levels intracellularly, and we have to watch that, especially in PrEP. NNRTIs, again, keeping it simple, Reproductive, no interactions of Sovereigns, absolute interactions with oral contraception, with progesterone-only pills, and with implants. And so really the preferred agent is injectable DPMA. Dolutegravir and ritonavir, DPMA injectable every 3 months is preferred. Oral and implants are not. Atazanavir, ritonavir, lopinavir, ritonavir, in general, all methods are okay. Dolutegravir, anything with cobicistat, we don't have good data on contraceptions with cobicistat-based drugs. And then integrase inhibitors, again, putting a lot of data together, keeping it simple, all are okay with all forms of contraception. And then I do want to address a very great point that someone brought up, Dr. Quadri, that absolutely this call for increased viral load monitoring in low-income settings has not only been made, but has been instituted in a number of countries worldwide. She mentioned Botswana to increase viral load monitoring to every 3 months. And I would refer you back to this poster that I mentioned on the bottom of on this page that you can see abstract 674 CROI 2019, a really nice poster by Dr. Lasowski, which was actually looked at the different countries and summarized where we are in terms of the frequency of viral load monitoring recommendations for pregnancy. Okay, so so in terms of, proceeding ahead, we just went past contraception. I now want to talk about where we are in the world with more data needed and kind of end up with this. There was a really nice symposium at CROI this year, which had a series of talks of reproductive potential. And I think this is a really nice slide that's presented by Dr. Ann Lyerly, again, the Associate Director of Bioethics at UNC, where she says that the fundamental misconception that all women are always pregnable and therefore, through the magical operation, the mind characteristic of unconscious sexism, always pregnant, has informed how we think about studying drugs of women of reproductive age. Women to this day only represent 23% of participants in antiretroviral research. That was as of 2016. It's maybe a little bit better, but it's not. It certainly isn't 50%. Of course, worldwide, over 50% of those living with HIV are in women, and thus the antiretroviral treatment trials should reflect that 50-50 proportion, and that is absolutely not the case in 2019. And really, what she talks about is that we need to shift our burden of justification of how we justify if pregnant women should be in trials from justifying why they're included to shifting it to the question of justifying why they're being excluded. And I do think that these conversations are more robust and they're more active about the limited data that we have of antiretrovirals and any other drugs for any other condition in pregnancy. And there's a very active discussion about that. And as always, I think HIV is leading the way in terms of informing that. So, for example, these are draft recommendations that were put out by the FDA as of April 2018, and it's called Pregnant Women, Scientific and Ethical Considerations for Inclusion in Clinical Trials, Guidance for Industry. And if you look at those draft recommendations, they include a lot from our very own in the HIV field of a lot of discussion of this really wonderful article from CID in 2014 of Designing Drug Trials Considerations for Pregnant Women, and a lot of discussion about what we should be thinking about from the HIV world. And what this draft recommendation statement says is that studies in pregnant women are justified. They're justified in the post-marketing setting if they've already been FDA approved. There's adequate non-clinical data available. They are justified in an established safety database, including post-marketing surveillance of pregnant women, and efficacy cannot be extrapolated. In pre-marketing studies and investigational studies, if there's adequate non-clinical data available, like in pregnant animals, then that is helpful. But a clinical trial holds the likelihood to direct, if this clinical trial is going to directly benefit for the pregnant women, and because there's only a drug that can be used and gotten in the clinical trial, for example, for cancer medication, then pregnant women should be allowed into the trial. And then finally, failure to establish the dosing regimen, safety and efficacy of a treatment during pregnancy is going to compromise women and fetal health. And that's where we are because we have so little data. And that's what I really want to end with. So the development of accessible treatment options for the pregnant population is a significant public health issue. So I'd like to conclude that there are many antiretrovirals available in 2019. We don't have enough data on many. There are PK changes during pregnancy that we have to consider. That Dolutegravir is not recommended in the first worldwide, but we need an informed decision-making and a patient-centered approach. And generally, NRTIs, Dolutegravir, Atazanavir, Ritonavir, and Dolutegravir are the preferred agents in the high-income setting with Dolutegravir after the first trimester, but it's ethical and imperative to study sex differences in ARVs in pregnancy and postpartum. And I will now end there and take any questions from you. I do want to make a plea that in the U.S., register your patients in the antiretroviral pregnancy registry, and anyone who's pregnant and on an antiretroviral medication, and the website is provided here. I'd like to thank IAS-USA for the invitation and the clinic that I have the honor to direct at UCSF, the Ward 86 HIV Clinic, and my colleagues at UCSF, Diane Havlier, Catherine Koss, Deb Cohen, and also my hair laboratory. So any questions that I can answer, and then we can get to our post-test questions. So anyone who has questions, please put them in. And I'm going to read out this first post-test question, which at this point we had already looked at, which drug is first line in both the DHHS guidelines and the WHO guidelines for use during pregnancy. The Dolutegravir after the first trimester, Prevalence, Tenofovir, alafenamide, or Atazanavir, Ritonavir. Please vote. Okay, I think we're still, okay, so the poll is closed, and 2/3 of you said Dolutegravir after the first trimester. That's correct. Efavirenz, at least on the DHHS guidelines, is not considered preferred. It's still considered alternative and not first line. This is first line on the WHO guidelines. And then TAF, there was a confusing nomenclature here. It says Tenofovir, alafenamide, and it says TDF instead of TAF. So I'm sorry if that's my fault, so completely that was confusing, and that is not recommended on any guidelines because we don't have enough data. And then Atazanavir, Ritonavir is first line on the DHHS guidelines for PIs, but third line on the WHO guidelines. Okay, next question. So what is the rate of neural tube defects in the general population? Is it 0.1%? 0.4%, 0.67%, or 0.9%. And yeah, great. Okay, great. Majority of you said 0.1%. That is absolutely true. Again, the 0.67 is what we're sitting with right now with Dolutegravir. As of the updated data, 0.9% is what we've seen with Dolutegravir in the May 2018 release of the TESAMA cohort data. So trying to get it down to 0.1% by having more women, again, in the denominator, eventually the TESAMA cohort, and the numerator staying the same. Okay. So let's answer a couple more questions that have come up. One was if someone is on Stribild and gets pregnant, are we supposed to switch them? And Stribild, remember, is a combination of albuterol, cobicistat, TDF, and FTC. So in that case, TDF, FTC is fine. Albuterol, cobicistat, given the data I showed you from Impact 1026, in the world right now, we are concerned about second and third trimester exposure to both albuterol and cobicistat, and the recommendations would actually be not to continue but to switch. Now, say the woman loves her Stribild, and that's what works for her, and that's what she's found. It is important for her to be on the medication that she's most comfortable with. And thus the other, if you're going to continue her on it, then more frequent viral load monitoring is indicated because of these PK changes. Recently had someone ask me about this, and we recommend grapefruit juice in the third trimester because that can actually boost levels of albuterol. Grapefruit juice is a pharmacoenhancer in and of itself. So if the cobicistat levels are going down, then the grapefruit juice could help increase the albuterol levels. It's theoretical, but or it's definitely known, but there's never been a study with that. So again, it's always a decision between with the patient. So then a question is, we already answered the one that absolutely countries are changing their guidelines on the frequency of viral load monitoring in Botswana, and I'd refer you to that poster from CROI 2019. And then there is a question about for pregnant women on atazanavir, ritonavir plus TDF, should the dose of atazanavir be increased in the third trimester to 400 milligrams? It's a great question. Atazanavir absolutely levels do decrease in the third trimester, and there was much talk about it. There was much discussion. There was experts weighing in on both sides. Right now, the current expert opinion is not to increase atazanavir levels during the third trimester, atazanavir dosing during the third trimester to 400 milligrams with the 100 milligrams of ritonavir to increase atazanavir levels. That is where we stand now with the guidelines, not to increase. But it's a great question and has been oft debated. And then there is a question with, since there are existing ARVs available in pregnancy, it would seem that studies of ARVs in pregnancy would only be considered ethical in phase 4 after efficacy is demonstrated. Would you agree? This is a very good question, and I think that's the active debate that's going on right now. No question that a woman has to be treated during pregnancy. No question that if there hasn't been animal data or other data that suggests that the drug is teratogenic, that most drugs are not teratogenic. And what the debate is going towards is that pregnant women should be included. On the other hand, what the FDA is recommending is they should be included if they do not have any other options. So, for example, if a woman has MDR HIV, multi-drug resistant HIV, there's nothing else she can use but ipilimumab, or her HIV will not be treated, then she should be allowed in the ipilimumab trial to begin with, because that was what was best for her. So these are great questions. These are absolutely the debate. What I would say, and this is where I weigh in on it, or this is where I fall on it, is that drug companies and clinical treatment trials need to make an effort to enroll adequate numbers of women, period. By enrolling adequate numbers of women, you are, by definition, enrolling adequate numbers of women of reproductive potential, because during a certain phase in women's life, they have reproductive potential. We don't work hard enough. Drug companies, in my opinion, do not work hard enough to enroll adequate numbers of women. We're getting better in some ways, and we're getting worse in others. At every CROI, when they talk about the treatment trials, most of us who work in women are staring at the demographics page about how many percentage of women were enrolled. It's never 50. Sometimes it's so much better, and it's 33, like in the recent injectable trials. But sometimes it's still at 16% women. And so the plea I would make, and this has been made for a long time, but a lot of people, is enrolling adequate numbers of women in trials of new antiretroviral agents. And not necessarily recommending 2 forms of contraception, by the way, because no one uses 2 forms of contraception. Okay, and then I worry a bit about efavirenz with so many of my patients with profound mental health issues and also ability to take multiple pills a day. Efavirenz TDF to FTC is a single pill combination, so that wouldn't require multiple pills per day. It is absolutely true, however, that efavirenz has been associated with depression, anxiety, CNS defects, insomnia, vivid dreams, even in rare instances, psychosis or suicidality. So it does have those effects. On a population level, efavirenz has been used very frequently. It was the first-line therapy for many years up till the guidelines changed worldwide to Dolutegravir, and there are many people who tolerate efavirenz, but it is an extremely important point that it does have CNS side effects. It's what demoted efavirenz here in the U.S. On the DHHS guidelines, and with depression being prominent, if there is a component of depression during pregnancy, I think it's a very valid concern. And then a woman on a DEFC becomes pregnant. Should she consider with this med, even though TAF is in the combination and an RTI is lower than usual? So that's a great question. A DEFC is a combination of rilpivirine, tenofovir allocenamide, and emtricitabine put together in one pill. And there are two problems with two of those drugs. One is rilpivirine levels, which is an NNRTI that's alternative on the DHHS guidelines do go down in pregnancy, and that TAF is not recommended because we don't have enough data. So what I would say here is if she loves it and that's what she takes and that's what works for her, then continue it, but a little more frequent viral load monitoring, and watch out for a couple of things. Rilpivirine has to be taken with food. If she's throwing up a lot, that's not going to work because you need to take it with actually a solid meal and not even with a protein shake. It has to sit in the stomach to absorb. Second is that if she's having a lot of heartburn, not a great drug because proton pump inhibitors will absolutely make it, well, you can't use them at all. It really just reduces rilpivirine exposure, and then even H2 blockers have to be elaborately spaced out, and I still wouldn't use them. So I very much worry about that. So it is, if she has a perfect pregnancy, no heartburn, no nausea, no throwing up, then maybe that's the right thing to